Now I call upon Dr. Bimal Sahani sir for his talk on fetal cardiac anatomy and its variants.
A very, very good morning, and at the very onset, thank you very much to the organizing committee for putting up a grand show. What was really heartening was the participation of the young brigade, especially the women's wing. I think you've really taken it upon your shoulders, and the future for Marathwada looks very, very good. Because there was a time it was like Anirudh and Bimal, and then we felt we just need to back off. Unless we don't back off, people will not come up forward, and this is one wonderful thing that I saw. And very happy and like very proud moment for me when I heard the last talk from Vishnu. I think the simplicity with which he has taken you through cardiac planes, and somebody who's your prodigy, and when they do it, it's far better than how you speak in your own lecture after that. So thank you very much, but he has left nothing for me to speak, honestly speaking. So that's why I changed my topic to some anatomy and some variants. So there is going to be a little bit of repeat on what I speak about. I had requested Dr. Kondekar on a WhatsApp message that if he can give me 10 minutes extra, but looking at the situation, whenever you feel you can stop me, I will stop there and then. Okay, when it comes to looking at the heart, this is all you need to see. Is it too huge? So are these screening planes too complicated to obtain? Very honestly speaking, yes, it is a complex structure, but it is not. It is just about looking at things. Now, it is at what, see, you just have to imagine. Anatomy is all about imagining. See, you need to think at what, if I'm taking this particular plane, at what level I'm cutting this plane. So once you're, like, this is number one. This plane, when I'm cutting, that's why, like Vishnu said, you always have to begin from the abdomen and then go up. So when you cut this here, you're going to get a situs view. And this is how you're going to look for. You're going to look for what Vishnu has said, that you'll see the stomach, you need to look at the aorta, the IVC-aorta relationship, and the gallbladder, and you take advantage of this situation to decide the visceral situs. Then comes your second important plane. As you go a little cranially, you will get the four-chamber view. So you just imagine where you're cutting. So the problem about missing or misdiagnosing or wrongly labeling something as abnormal is because you're not in the right plane. The plane is important. And then this way you get the four-chamber view plane. Then you go, now I want the left ventricular outflow tract, I want the right ventricular outflow tract. That is where you may require. So what Vishnu talked about is a sweep technique, but at some time you need to do a little bit of rotation also. And this is where you go about and look at the LVOT, and you're going to get the left ventricular outflow tract. I will show those in images also. And you go up and take a short axis view. So we are basically, gradually going from caudo to cranially, and even this view, what we actually also label as the view for the ductus arteriosus transverse long view, actually is also an RVOT view. But then when we look at, when we talk about an RVOT, we basically want to also define the pulmonary arteries, the bifurcation which takes place, and that is the short axis that comes up there. And then you move up. That is now the time that you are actually getting into the superior mediastinum, and there you will get all the planes of the three vessels that will come. The three vessel view, the three vessel tract. So you will get the three vessel view again, which is more of a line dot stuff. Or you will get the three-vessel tracheal view, where you have a line dot kind of an appearance. We will just speak a little bit about that also. And then you move into an sag plane and try to get the planes for the bicaval view, the ductal arches and the aortic arches. Are these planes important, or just your axial planes are enough? Yes, as a part of your basic or extended basic cardiac screening, that is enough, but the arch views, the sag views become more important when you want to come and pinpoint to a particular diagnosis, and that is how you will get the bicaval view, and you draw, you cut, then maybe little to the left and to the right you will get the views of the arches. Then you go about and say that yes, I have done a fetal echo. Simple? Simple or not simple? Very simple. Okay. So, but as a beginner or as a part of your routine mid-trimester scan, what you need to do is these 5 views. The situs, the 4-chamber view, the LVOT, RVOT, and the... Now, this actually is basic cardiac screening. People felt that looking at the heartbeat, sometimes people tell me, I do only basic cardiac screening. And I said, okay, what do you see in basic? No, I look at the heart rate. No, that is not basic cardiac screening. Then, if you're looking only at the 4-chamber view, again, yes, it used to be basic cardiac screening before, but it is no more. So this was called as an extended basic screening, but now this has become a part of the basic. And as Vishnu pointed out, your basic extended cardiac screening should also be with color. The other views, the transverse aortic arch view, the transverse ductal arch view, which we saw, I will mainly be showing you these views, but it is actually, you see, I'm just taking a sweep, caudocranial sweep with a little tilt here and there. So I'm seeing I saw the situs, I saw the 4-chamber view, slight rotation, I'm getting the LVOT, and as I go up, I am getting the RVOT which is coming, and I get the 3-vessel tracheal view. I go down, I'll be able to see the transverse view of the aortic arch. Everything comes in one sweep. This is called one sweep fetal echocardiography. And this is one video that I have taken, and I have stopped, and I have got all the views from this one sweep itself. No rocket science in that. Yes, it is demanding a bit, but if you just go about looking at things in a proper manner, you'll be able to establish everything. So, 4-chamber view is a huge list of things that we need to see. Vishnu has already covered all that, but he's spoken about cardiac position. Now, I will ask you this question. Here, you have the heart in the right side of the chest with the apex pointing towards the left side. Here you have the heart on the right side of the chest with the apex pointing to the right side. Which one is dextrocardia? The second one. How many of you say second one? 1, 2, 3, 4. Okay, there are quite a few. And how many of you say first one? Yeah. He's already made a point there that yeah, both of them are dextrocardia. So the whole issue is, I see a lot of reports on that. There is a CPAM, and there is a CPAM, you say that the heart is pushed there, but that heart also is a dextrocardia. So dextrocardia by definition is only that the heart is located in the right chest. It is not giving you any information about the situs, the axis, the anatomy or chamber organization at all. Now let me just show you what is happening. This is the heart. This is what the heart is looking at. When I say dextroposition, I'm talking about a parallel shift. The heart is shifting parallelly. Now this is a parallel shift. So there is a difference between parallel shift and change in axis. Now, this way, if it is going parallelly, then I'm talking about extreme levo position. That was dextro position. And if you look at things like when you say there is a dextro position, then you have to think not within the heart. Of course, there can be within the heart, but mainly you have to think, is there something which is pushing it there, or is there something which is pulling it back? Pulling it to the right side. So then you can think of all these masses or foreign things that can happen in the left side of the hemithorax, which is pushing it, or there could be a right lung agenesis or hypoplasia. Whereas in dextroversion, you will find that the heart is in the right chest with the apex pointing to the right. Again, the anterior chamber could be the RV, could be the LV, it could be a mirror image, or it could just be moving that. Whereas when we talk about axis, you have, this is a normal position of the heart, but it is the axis which is tilting on one side or the axis tilting on the other side. So this was a parallel shift. This is this way, this is this way. There is a difference between the two. So for each heart position, orientation of the axis can be to the left side, to the midline, or to the right, and this must be mentioned separately. So I feel rather than using word as dextrocardia or dextroposition or dextroversion, it is better to put all those things together. You can say the heart is on the right side with the apex pointed towards the left side. The axis is so and so. So that is how you need to describe so that the person who is reading the report understands what you are actually trying to say. Now, four-chamber view, he has spoken a little bit about it, but there is something called the area behind the heart. I'm not going through the complete four-chamber view, that has already been covered. The area behind the heart, let me tell you, has become a very, very important thing. We don't look there. We look at the AV valves, we put in color, we see all those things, we look at symmetry, we look at position, but we don't look down. And here you can see with this paper, they have evaluated 613 fetuses with congenital heart disease. 69 cases had abnormal finding in this area. So even if sometimes the four-chamber view is looking normal, you could, from the area, so area behind the heart could give you a pointer towards an existing congenital heart disease. So you need to, what all are you seeing? You're seeing the posterior part of the left atrium. You see both the pulmonary veins. You are seeing a descending aorta, which is to the left of the spine. That is also very important there. If you see the descending aorta to the right of the spine, that all itself tells you that there is a possibility of a right aortic arch. And then the esophagus and the azygos, these are all the things that you look for. And I will, important thing for me is that the posterior wall of the left atrium will always be kissing the descending aorta. There is no space between the two if you are in the right four-chamber view. If you go a little oblique, you will end up wrongly diagnosing it, but normally that is going to be there. You will see the pulmonary veins which are opening. So when you see two pulmonary veins, also see to it that they are opening separately into the left atrium, or you can go into a transverse and confirm. This is what we call as the Crab sign there, and look at these other cystic areas. Now both esophagus, if you see one structure and it is filling and going back, then it is probably an esophagus. Or if you are seeing that there is another two cystic areas, two cystic lesions there, and the other one is equal to that of the descending aorta, then you think in terms of, so significant size vessel which will be seen behind is always going to be the descending aorta. Now, all these things you can find here. With a shortage of time, I'm actually running a little fast, but here you see the four-chamber view is normal, but I'm seeing two cystic structures behind there. So that is one thing here. Here I'm seeing a vessel, I'm seeing something what we call as the confluent vein there, area behind the heart. So the posterior wall is not kissing the descending aorta. There is a vessel which is seen there. This is what we call as the twig, which is telling me towards TAPVC. And then this was the same thing I was showing you. I'm seeing two cystic structures there. That made me think of, there I saw that, of course, this one is a dilated azygos that I see there. I go down and I find out that the IVC is interrupted and there is an azygos continuation. My diagnosis of I interrupted IVC with continuation of azygos. Then you look for the other thing. There were some other pointers which told me this is the left atrial isomerism. So area behind the heart is also, the anatomy there is also very important. Now, he spoke about the morphology. Now, which among this is the most dogmatic sign to call a ventricle a morphological right ventricle? When we talk about morphology, we say, okay, the left atrium is closest to the chamber which is closest to the spine is the left atrium, so this automatically becomes the right atrium. So this is on the left side, the clean ventricle, the moderator band, and the tricuspid insertion is more apical. So my question is, which of these is more dogmatic? How many for moderator band? How many for AV valve? Yeah. Moderator band you can also see in the LV sometimes. It is, remember, this AV valve is married to the ventricle. It will always be the tricuspid valve. If the ventricle moves from this side to that side, then the tricuspid valve will move with it. So it is important. And the tricuspid valve, yes, you see at times, even normal cases, you actually see that both are, there is a linear insertion. It has been documented also that it could be a normal finding at times. But one study by Rabi Choi and their group, they realized that in those cases, the plane was a little more cranial than the normal this thing, and that is why that thing happened. But even if you see a normal heart with no AVSD and linear insertion, that also becomes important, because it was also seen that they were present in cases of trisomy 21. So it also becomes a marker for that. Now here, this is the left side, this is the right side. Which chamber is the right ventricle? The one which is on the right side. So what has happened is, there is a switch. There is a switch which has happened. This happens in TGA. I will tell you one more sign. Now look at this color. Once you put in color, there is a red which is going in, there is a blue which is coming out, right? Can you see the red and the blue happening? Now if you see the left side, this blue is always going in the morphological left ventricle. This blue will be always along the interventricular septum, whereas it doesn't happen with the right ventricle. This is a very good sign actually. I feel this may turn out to be a more dogmatic sign than any of these. And now this is a case of CCTGA, the same case which the clip that I showed you before, and you can see here, because this we knew was the morphological left ventricle, and you can see this blue, what is happening is along the interventricular septum. Start using it from tomorrow. You will become very confident in a few days that what I am saying is right. Then outflow tracks. We've already gone that. So outflow tracks are seen in two methods. Sweep method. Sweep method, actually you don't get a very, very good LVOT. You get more of a 5-chamber view. There is a slight tilt here. And so you keep sweeping down, and but this is the view that you're going to get for the RVOT. But if you use a rotational technique, you will find that you get a fantastic, the complete view of the LVOT, and you will also get the short axis. So short axis will always come when you do a little bit of rotation, and that rotation has to be done on the opposite side of the the outflow tract that we are looking for. And then this has already been covered, that these are the points that you need to look for, and you need to look for the septo-aortic continuity and the aortomitral continuity here, and here it will be branching. But so this has already been covered. But very important thing, when you are looking at the outflow tracts, see to it that the outflow tracts are crossing each other. Crossing each other where? The moment they leave their ventricles, they should be crossing each other, and you can then use, like this is how it crosses. That's a fetal stick that I have done, and this is how you will find that they are crossing each other. So when you're looking at the LVOT, you should see to it that, okay, this one is going this side, this one is going that side. Because if they are parallel to each other, that is giving you an indication to look for some particular cardiac abnormalities there. Then for the complete 3-vessel view, these are the multiple planes. So we are actually in the superior mediastinum, and there we are looking at all these things. So you have the 3-vessel view, which is seen first. Then you will get again the transverse ductus arteriosus view. You will see the transverse aortic arch view here, and the 3-vessel tracheal view as you keep going up. And so these views are very, very important. Everything. Forget all these 3 views. I will say concentrate on the 3-vessel tracheal view. A combination of a 4-chamber view, the LVOT, and the 3VT view is one of the best thing for you to make any kind of a diagnosis which is available there. So for 3-vessel view and 3-vessel tracheal view, again this is the same method that we are following. And for the transverse aortic arch view, it is again on the sweep technique. I'm not getting into it. 3VT view, we know that both of them, the pulmonary artery and the aorta, the ductus arteriosus and the aortic arch should form a V, and that V should be to the left of the spine. And we also know from Vishnu's lecture that there are few things that you need to look for. The number of vessels is 3. The alignment from the left to right is the pulmonary artery, aorta, and the SVC. The size, I don't know why some authors have said both of them, both great arteries of equal size. They're never of the equal size. There is always the pulmonary artery is a little larger than aorta, and the aorta is larger than the SVC. The ratio between pulmonary artery and aorta could be up to 1.2 normally. The direction of flow in both is antegrade, and the relationship to trachea is both ductus arteriosus and aortic arch are to the left of the spine there. So what abnormalities now, when I'm looking at the 3VT view, I look for, are there any abnormalities in the number? Is there any abnormality with the arrangement? Is there any abnormality with the size? Am I finding something which is smaller or larger? How is the direction of the flow? Are there any interrupted vessels? Is there a communication between the great arteries? And how is the relationship with the trachea? And also, this view also gives me an opportunity to look at the mediastinum and the thymus there. One algorithm I will give you, which actually I had recently done it for Nagpur. Now, because I don't have time to show you images, number. If you see 4 vessels in a 3VT view, it could be, and the 4th vessel could be an LSVC, or it could be a vertical vein of supracardiac TAPVC. If you see 2 vessels, one great artery and one the SVC, then see, is this great artery of normal size or is it large? So if it is of normal size, then go oblique. And if you see that there is one vessel, but it is of normal size, just turn oblique and you will find that the second vessel was behind that, and you will see parallel vessels. So think of TGA or DORV. If you find a single great artery of large size, then that could be compensatory. That means the other vessel is absent, so it could be either a common arterial trunk or a pulmonary atresia that is giving rise to a dilated aorta, or an aortic atresia giving rise to a dilated pulmonary artery. Look at the size. If the pulmonary artery, now we concentrate on the pulmonary artery, is narrow, think of TOF or AVSD. If the pulmonary artery is dilated, think of absent pulmonary valve syndrome or post-stenotic dilatation in pulmonary stenosis. If the aorta is narrow, think of coarctation or hypoplasia of aortic arch. If it is dilated, think of aortic stenosis, post-stenotic dilatation there. If the arrangement, what was the arrangement? Pulmonary artery, aorta, SVC. This was the arrangement that we saw is normal from left to right. And if you find that if there is an abnormality in the arrangement, it could be an LSVC with absent RSVC. So you may get an arrangement as SVC, pulmonary artery, aorta, and aorta. If there are interrupted vessel, think of interrupted aortic arch. If the direction of flow is, there is a reversal in the aortic arch, there is going to be a left-sided obstruction, and hence you need to think of HLHS, critical aortic stenosis, interrupted aortic arch, or coarctation. And if there is a reversal in the ductus arteriosus, which Vishnu showed in his first trimester thing, then think of right-sided obstruction, PA-IVS, that is pulmonary atresia with intact ventricular septum, PA-VSD, tricuspid atresia or severe pulmonary stenosis. And if the relationship with the trachea is abnormal, so you see a U sign, then it is a right aortic arch with left ductus arteriosus. If you see a right V sign, then it is a right aortic arch with right ductus arteriosus. If you see a figure of 6 sign or a complete concentric ring, then it is a double aortic arch. And if you find that the right subclavian artery is going behind the trachea, then it is ARSA. I'll keep it for a second if you want. Just keep it with you, and anytime you find anything on the 3VT view, you can just go and then start thinking. Then go ahead and do your fetal echo. Look for things that, okay, now I'm thinking in terms of a pulmonary atresia with intact ventricular septum. Let me look at the color flow and use this thing. Then in the 3VT view, at times, normally also you may see an azygos. Of course, this was a case which was of dilated azygos. So you should, don't worry. Think about it, where it is coming from. Go sag and look into certain things. And transverse aortic arch view, we will sweep. As you are going, once you leave the 3VT view, make it an habit. If you want to pick up ARSA, you have to start looking for the normal right subclavian artery, and as you go cranially, you have left the 3VT view, you will find that there is a vessel which is going anterior to the trachea, and this vessel actually goes and bifurcates. This vessel bifurcates. So just seeing one vessel anterior to the trachea does not mean that you have ruled out ARSA. This is the innominate artery. Then it divides into the right subclavian and the right common carotid artery. So even if there is an ARSA, you will see because that becomes the right common carotid that you are going to see there, and brachiocephalic vein. When we are talking about other planes, now as you go across this, you will find a vessel which goes transversely over the aorta, and you can put in and see color. The color in the left brachiocephalic vein the direction of the flow will always be from the which side? Left side to the right side. It will be left side to the right side because the left side we don't have an LSVC. That is why when you have an LSVC with an absent RSVC, you find that there is a flow from the right side to the left side. There, the thymus. How many of you look for thymus as a routine? 1. 2. Good. Start looking at the thymus. You can look at the thymus in multiple planes. In the 3VT view plane, also you will find that there is a thymus sitting there. And actually, I love to do it in the plane of the brachiocephalic vein, in this particular plane. And actually, if you use low PRF, you will find that these are the internal mammillary arteries, and between that is the thymic box. Now, I will ask you, this is the brachiocephalic vein. Is there something wrong here? This brachiocephalic vein is actually touching the sternum. Yeah, there is no thymus at all. There is no thymus at all. But you will say, one day when I see something and I have to look for thymus, that day I am going to look for it. No. You need to start looking at it normally. You see 100, 200 cases and you will find that you are able to then one day say, oh, there is a thymic hypoplasia. And then you can use the thymic thoracic ratio, which has come from the Rabi-Choi group, where you take but of course his ratio is on the 3VT view, where you take a ratio, the AP diameter of the thymus and the AP diameter of the mediastinum. Normally it is 0.44 and in 22q11. That is why it is very important that if it is 0.25 or less, then you need to think of the DeGeorge syndrome. And the longitudinal arch views, these views you need to practice, because the day you find that yes, you are finding that the aorta is appearing narrow, or you are finding disproportion, the LV is appearing small, I need to go and look for the isthmus. I need to look for any shelf or coarctation which is there, and the aortic arch is going to show you branches, and the vessel which comes in between here is the right pulmonary artery there. And in where, though, you can do all this fancy stuff, you can use your 3D and your fetal stick and everything and get this, but your regular color is good enough. In the longitudinal ductal arch view, the ductal arch arises from the anterior aspect of the chest and it does not show any branches, and this is the difference between the two. So this is aortic arch is circular, which is an acute curve. This is wide, this is cantistic appearance, this is hockeystick appearance. This is going to show branches, this is not going to show branches. Here it arises from the mid part of the chest, the aortic arch, and this arises from the anterior part of the chest. Now tell me, here I am showing you both the arches. Anything wrong? The arch which is arising from the anterior aspect of the chest is the one which is showing branching. So that is the aortic arch. So what are we dealing with? We are dealing with transposition of the great vessel. So the arch views are also helpful. There is a third arch also, and that is an azygous arch. You may not see it normally, but thin patients with a good, if you are in your low flow settings, you will find, but the direction of the flow in this arch is going to be towards the heart. It's going to come down from here and go towards the heart there. This was the same case. This is a dilated, because here the azygous was dilated. You can see so you could confuse this to be an aortic arch. Okay, it is appearing very, very narrow there. But this is the aortic arch. The direction of the flow is from the heart and going down. Here it is coming from down and going towards the heart. And there you see an interrupted IVC there. And the bicaval view is important. You see both the and both the vena cavas which are opening into the right atrium there. Some anatomic variants. What are anatomic variants? These are not rare. They are present in quite a few cases, but they do not cause problems by themselves. But can you just shrug them off? No. They become a marker, or they become a pointer towards looking for other abnormalities, because they could have associations with other cardiac abnormalities or this thing. One of the most popular variant is an echogenic intracardiac focus, which is nothing, just a calcium deposition in the papillary muscle. And that is something which is really, in the Indian population, definitely, confidently you can say that it is a variant, though it is a marker for Down syndrome, but isolated as a finding, it does not really make a difference. The word isolated is into capital letters, inverted marks, whatever bold you want to make. I'm specifying. If it is isolated, then it doesn't have any problem. The left superior vena cava, the LSVC, is also a variant actually, where you see bilaterals. This is a 3-vessel view, and you see that there is one vessel here and one. So you are seeing RSVC there, there's an extra vessel there. Now look, the direction of flow in both of them is the same. So this cannot be a vertical vein of a supracardiac TAPVC. You will find other changes here. You will see a bleb in the 4-chamber view, and you will find a dilated coronary sinus. If you go into the SAG, you will find an LSVC, which is going to give you a smoking pipe appearance there. And the brachiocephalic vein in bilateral SVC is always going to be absent. If you have a bilateral SVC, because left is also getting an opportunity to drain, the right is also getting a drain, so there is not going to be there. If you look at the coronary sinus, the problem with LSVC is if you don't pick it up, that's okay. Because the coronary sinus is dilated, you end up calling it as an ASD, primum ASD. So confirm and put in color, and you will find that in a coronary sinus, the flow is always going to be from the left side to the right side. ASD will give you a flow from the right side to the left side. Small things become very important when you make a wrong diagnosis. You unnecessarily put them through a pressure. At times, as I said, there could be an LSVC with absent RSVC, and here you will find the alignment to be different there. And aberrant right subclavian artery, an important thing, you look for ARSA, and you will find that here, you know, this is a 3VT view. As I said, the right subclavian artery normally is going to be seen when you leave the 3VT view. Here you are seeing it in the 3VT view, and this will go straight towards the shoulder, which is going behind the trachea there. And you can see now this is a normal. This is a normal that I'm seeing. Okay, it is going anterior. This is the trachea. It is going anterior to the trachea and down, whereas an ARSA is going in the 3VT view, and it is going behind the trachea straight towards the shoulder. That makes it, all these other things are relationship to trachea can also, but an important thing which is genuinely a variant, and why I am saying this, you should know about it, because you may call it as a hypoplastic thymus, because you are seeing the brachiocephalic vein somewhere closer to the sternum, and that is an intrathymic course of that whole thing is the thymus, and the brachiocephalic vein is going through the thymus, and actually it takes an S shape. It takes an S shape and goes and meets the SVC. Just be a little careful about that. So to conclude, identify normal as normal. That's the most important thing. Forget making a diagnosis. All that will come secondary. First, normal is normal. For that, you should know the planes, anatomy of each plane, and what to see in each plane you should be aware of. Identify abnormal as abnormal. And for that, pattern recognition is important. That gradually you will get used to, and then make a final diagnosis. Thank you very much.
Now I request our moderators to please felicitate Dr. Bimal Sahani, sir.
It was a great experience to hear Dr. Bimal. He is our own celebrity speaker. Second thing,
Hearing it from my teacher is such a wonderful thing.
he's an accidental teacher. He is my classmate basically. I want to ask whether in extended cardiac examination, should we have a pulse wave Doppler, or we should involve fetal echo only? Okay.
What I say is, you anyway want to measure something in an M mode, I like to do my through that. Usually, or then sometimes it is better if you want to do, you can use the mitral aorta junction, which will also tell you about both the atrial and the ventricular rhythm. But subjectively, if it is comfortable, you can use that. But Otherwise, all these waveforms and everything we take for when there is it is a fetal ego.
बिमल के बारे में अगर बात करना है तो सूरज को दिया दिखाना है. अभी किसी को बड़े आदमी को बुलाना पड़ेगा तेरी तारीफ करने के लिए. यू आर माई क्लासमेट, यू आर माई गुड फ्रेंड, आई एम प्राउड ऑफ यू. और जब आप बोलते हो तो ऐसा लगता है आपका लेक्चर चालू रहे और हम सुनते रहे. सो यू आर सो नॉलेजेबल. ये टालियां तेरे लिए, मेरे लिए नहीं है. ओके, थैंक यू विमल.